So good afternoon, everyone, and you're very welcome to today's webinar. I'm delighted to welcome and introduce Professor Ismail Gogenur, who is the Director at the Centre for Surgical Sciences for today's webinar. I've known Professor Gogenur for a long number of years now, and we've enjoyed an excellent collaboration on the use of electroporation or pulsed electrical fields for gastrointestinal cancer treatment and the potential associated immune engagement that is triggered. Professor Gogenur, just to give you a brief background on the professor, he founded the Centre for Surgical Sciences in 2014, a research unit focusing on physiological changes caused by surgical procedures. Professor Gogenur is an author of 6 book chapters and over 300 scientific publications in peer-reviewed journals. His research activities have primarily focused on surgical pathophysiology and on understanding the individual risk profiles of patients undergoing colorectal cancer surgery and the effect of these on short and long-term oncological outcomes. Professor Gogenur has been the principal investigator of multiple clinical trials and country principal investigator of 3 international multi-center clinical studies. Professor Gogenur and his team have extensive experience with the EndoVE device for GI cancer electroporation, and I'm delighted we have the opportunity today to hear about his experience and thoughts for the future. So Professor Gogenur will provide a 30-minute presentation. That's the plan this afternoon, and we'll follow that up with a Q&A session afterwards. And the plan is to record the session here today as well and share that afterwards. So with that, I'll hand you over to Professor Gogenur.
Declan, thank you very much for the kind introduction, and hello to you all. It's going to be a 1-hour webinar where I will be diving into this subject regarding how we can optimize our patient schedule for colorectal cancer surgery or for gastrointestinal cancers in general. My background is as described by Declan. I'm a colorectal surgeon, and a lot of what we're doing is trying to dive into this period with respect of surgery in order to make a case for how to introduce novel therapeutical treatments in order to move the patient's immune system towards an immune system where we can improve outcomes in patients scheduled for gastrointestinal cancer. I have a disclaimer, so to speak, because I'm looking into the literature produced regarding electroporation and treatment, not only within the gastrointestinal tract, also in solid cancers, where there is some very, very interesting data out there. My personal opinion and belief is that we need to try to see if we can integrate methodologies in translational science in our clinical trials in order to make a strong case for the use of electroporation. So hopefully for the next half an hour, I'll try to give you how we are approaching this subject and start by describing the clinical case for the patient with gastrointestinal cancer, and then by also using some of the scientific methods that we can use to read the outputs of electroporation, go into the clinical data and run through what kind of trials there are out there and how we at our units are integrating electroporation in the treatment of patients with gastrointestinal cancer. So basically, it's all about the patients, right? So in order to find out what is the most important outcome for patients with a newly diagnosed cancer. And I think that one of our biggest challenges with the vast development that there have been in the description of what factors are are affecting our patients' outcomes in relation to oncological therapy is to understand exactly what can we modulate in the patients, be it patients with stage 4 disease or stage 1 to 3 disease that are candidates for surgery. So we need to have a clear understanding of what the most important outcome is for a patient with a certain risk profile, and then approach this. So what kind of treatment would we give the younger patient with a 30, 40 years expected life expectancy, and the elderly patient where it's most important to maybe do symptomatic control of their disease. And in my opinion, electroporation for our clinic has these two potential benefits. So the patient with a rectal bleeding, where we can treat the patient and seize the rectal bleeding or stop a expansive growth of a rectal cancer or colonic cancer, or the patient where we can maybe envision that there's a longer standing effect of the treatment if we can ignite the immune system. And I'll try to make a more detailed description of what my thoughts about that. So just to set the path regarding where we can put in electroporation and where we can put in treatments in the treatment trajectory for the patient with different stages of cancer. A larger portion of our patients are in the first group. If we're looking into colorectal cancer, more than 80% of our patients are in that group. And I think that the question of immunological optimization is not just a question for stage 4 cancers. It's also for patients who have localized diseases, because we know that this is a challenge for many of our patients, that they will have recurrence of their cancer after surgery. And it's also important to understand that this surgical variation in treating our patients is also putting in a strong case for factors that we can modulate, because it's actually important. There's a lot of our patients that have, I'm very sorry for this busy slide. This is a Lancet paper published a couple of months ago, showing that up to 40 to 50% of our patients in the high-income countries are actually having complications, severe complications within the first weeks after surgery. And this is something that is of important. The reason why I'm putting complications into this into this equation is that having a complication is actually something that is affecting the immune system negatively. We're thinking that, and are affecting disease-free survival and overall survival and recurrence-free survival. So if you have a complication, it's a very strong indicator that the immune system is kind of reduced in its function, making it more difficult to remove micrometastatic disease in the patient, and therefore the patient has a higher risk of having a recurrence. And in that context, I think that whatever interventions that we can do in the neoadjuvant setting as surgeons is something that we should put into our focus with respect of preventing this high number of patients that has a recurrence after colorectal cancer surgery, for example. These numbers are obviously much higher if we're looking into upper GI cancer surgeries, oesophageal, cardiac, or gastric cancers. So how can we go in and try to modulate the treatment trajectory in order to kind of train the immune system, so to speak, before surgery in order to prevent this disease recurrence? And this is where I think that pre-operative neoadjuvant therapies are the ones that we need to be focusing more in the future in order to solve this problem for a large group of our patients. So just to sum up for the first couple of minutes, it's a truly an important outcome to have a recurrence after cancer surgery, and we do have a need for optimizing our pre and perioperative treatments in order to prevent recurrences. So how can we do this? I'll try to just make a overall view of some of the most important data out there that is actually showing that this context of approaching the immune system before surgery is probably something that is going to be highly relevant for a large group of our patients. Just actually recently, this morning, I read a study from Lancet Oncology, a publication before print, where they gave radiation therapy plus immune therapy and actually could increase the number of patients that have complete pathological response. And these were not just pulmonary non-small cancers, pulmonary cancers that was PDL positive. It was actually any pulmonary cancer or lung cancer. So in the colorectal field, and let me give you one of the most strongest examples, is clearly within this study from Nature Medicine last year, where the Dutch group made a treatment for patients with deficient mismatch repair tumors, and show that they could actually produce complete pathological response in those patients that had deficient mismatch repair. So those patients with microsatellite unstable tumors, you had more than 60% complete pathological response. Every patient responded to immunotherapy, but as I said, more than 50% had a complete response. So this is actually a short treatment for just 4 to 6 weeks with CTLA-4 or PD-L1 treatment, giving such a tremendous response that actually maybe in the future, this is going to be the only treatment for patients with a colon cancer. The important stuff for us is therefore to see, okay, how is this for those patients that have a mismatch repair? This is only 15% of our population. What about the rest? What about the 85%? How can we attack those patients' tumors in order to make an immune stimulation? And this is where we need to up our game, so to speak, and also think of this when we are designing trials for the future, also looking into trials with the use of electroporation, is to have some outputs and to look into what are the most important outputs when we're looking into a treatment response. And this immune infiltration measurement, by looking into just see how many T cells with the CD8 positivity is infiltrated, is actually very, very strong, and is one of these most strong measurements that we can use for predicting a response. So just a few words. My personal hope and recommendation for your clinics when you will make these trials in the future, or if you're already using it, is to collect samples, to do blood samples and do tumor samples in a methodology where you are putting in a treatment before surgery, and this is certainly the case for electroporation treatment. I will go through these slides very quickly. It's just to show you a range of possibilities that we can use by immunohistochemistry measurements, looking into transcriptomics and spatial profiling. We can also look into blood, again, by looking into transcriptomics and looking into circulating tumor cells or circulating tumor DNA. Certainly, we need to have some kind of validation that what we do with our patients before surgery is actually translating into a positive clinical response. So I will give you a very quick run through different interventions as a neoadjuvant procedure. Why I'm emphasizing this is actually to underline that I think that the reality for our patients in the future will not be one single treatment. I think that for a treatment like electroporation, as it is the case in my clinic, is that by the experience that we have in using it in patients with rectal bleeding as a symptom, as an accidental finding, we find that the patients are stopping to bleed the day we do the treatment. So this has a strong effect. And this is something that we need to put into consideration in the future, and we're doing trials for this. When we're doing a treatment for immune optimization, we really do need to have a focus on what else can we do in addition to electroporation, because the tumor microenvironment is not simple. So I will just give you a couple of examples of what else sound principles to stimulate the immune response in add-on to an electroporation treatment. One thing could be actually training the patient. So prehabilitation is something that is certainly going in as a very strong impulse to improve the patient's cardiopulmonary status. We can improve the performance status of the patient, and certainly improve immune function by just giving 4 weeks of training before surgery. Another thing that we are doing in our trial is trying to give, in our center, is trying to give immune stimulants, interferon or metformin. Another thing we're doing is giving a flu vaccine before surgery in add-on to other preoperative strategies. And finally, we're also doing microbial interventions on patients with right-sided tumors. All these, just to, I hope, make the point very clear that multimodal treatments is the way to approach these patients, where we actually right now, data-wise, are not quite clear on what is going to move the patients maximally with respect of awakening the immune system. So I will go into the more detailed studies regarding electroporation. I'll start with the irreversible approach. There is one platform called NanoKnife, and it has been established and used within prostate cancer and within pancreatic cancer. And I have been having these talks with Declan, and I can understand that they're also looking into possibilities to move into the field of irreversible electroporation, or giving higher energy into the tissue. This is certainly an area of research and clinical research where there are some interesting data that I will go into. The vast majority of what we are doing at my center is the reversible electroporation. And I will go through our studies in a setting of stage 4 colorectal cancer and upper GI cancer, advanced rectal cancer, and early left-sided tumors. So we started with this, I think actually it's now almost 5 years ago, together with Professor Julie Giel from the oncology section from our department, who is one of the pioneers starting up calcium electroporation and putting this on the map, so to speak, on metastatic skin cancers and upper GI cancers. And we have now a range of trials in collaboration with Julia, where we are looking into the effects of electroporation in GI cancers. Let me go into just a very, very brief surgeon's description of what's happening when we're doing electroporation. So this is the very basic mechanistic description of the reversible electroporation. Is how can we by permeating the membranes of the cells, make sure that extracellular content, this can be calcium as I write in the title here, it can also certainly be bleomycin, go into the cells and produce a necrosis or apoptosis, which is initiating a immune response due to a higher exposure of antigens on the surface of the cells. So this is a very basic and mechanistic approach or description, and this has certainly been proven in many in vitro studies and animal studies, and now also in more and more human studies, that this is the mechanism. So what we're doing by the electroporation is starting a strong immune response, and then reducing the tumor size and alleviating symptoms. So if we start in the irreversible electroporation area, This is a study from Nature Communications a couple of years ago. I think it really it was a strong study because it put out the early data showing in an in vivo setting that electroporation surely has an effect with respect of deploying the energy to the tissue, doing the necrosis, but you don't get the full bang for the money, so to speak, or buck for the money, or what is said. What you need to do is to add on immune treatment in addition to the electroporation, and this is what they did. That when they put irreversible electroporation and an anti-PD-1 drug, they could see a strong response in the animal model. This was a model of pancreatic cancer in mice, and showing that this was actually strongly potentiating the effect of electroporation to put in the immune checkpoint blockade. And this is a little bit, again, a busy slide, but again, just to show you that the center of what's happening is these CD8 positive cells that are associated with a positive response to the checkpoint inhibitor treatment. And actually, if you go in and block the CD8 receptors, you actually don't see any response. So the immune system is clearly the target for electroporation and the add-on of the immune treatment. So what, and this is just a slide of showing that there was a longer standing immunization by giving the electroporation plus immune checkpoint inhibitor treatment, that after rechallenging, actually none of the treated mice had tumors growing compared with those of the control group. So a lasting response, again, this is translating into a clinical setting, that this might be something that can have a longer lasting effect in our patients, either those being scheduled for oncological surgery or those patients that have stage 4 disease and having a longer lasting response. So a couple of, I think it was a couple of months ago, this study came out in surgery. It was the first clinical trial where it was the Martin group gave the patients having a locally advanced, non-surgically treated pancreatic cancer patients, giving them an open irreversible electroporation, and then adding on nivolumab treatment in addition to their surgical treatment. So starting the immune checkpoint inhibitor treatment actually very close to the electroporation, and then continuing it for the weeks after surgery. So this is the first published safety study in combination treatment in those patients that already had FOLFIRINOX. And they, obviously being a phase 1 trial, looked into the side effects of the combination treatment and the side effects attributed to just giving irreversible electroporation, and could see that there was not a high grade of side effects on either side, certainly paving the path for this patient group with less than 5 to 6 months of median survival, having them to move on to a phase 2 trial. What they could show that was that those patients that they had given combination therapy, and obviously one should take these data with some limited value because it's only 10 patients, but the median overall survival for those patients treated was up to 18 months, which is pretty amazing for those patients with advanced pancreatic cancer. So we have in my institution started a clinical trial resembling this, but with percutaneous irreversible electroporation for those patients with metastatic pancreatic cancer, and are focusing on those patients that have multiple lesions and treating one lesion and trying to demonstrate if there is abscopal effects on systemic lesions by giving combination therapy with irreversible electroporation plus immunotherapy, and we're also using nivolumab. So let me give you some other human trials. This is in a study from an Italian group where they treated patients with metastatic malignant melanoma, and what they showed was, again, putting the point in that it is probably through a stimulation of CD3 cells and CD8 positive cells that the electroporation works. So these doctors made this treatment in metastatic malignant melanoma and could demonstrate a clear increase related to the response of the electroporation, and also could see that those cells that are suppressing the immune response were reduced in these patients. So we are looking across patient groups with metastatic pancreatic cancer, and we're looking into patients with melanoma metastases, both, as you know, diseases with poor outcomes. So one of my colleagues, Dr. Akiam, and together with Professor Julie Gehl, had this trial looking into the electrochemotherapy for esophageal cancer. So looking in again in a phase 1 trial, looking into how the acceptance of these patients with locally advanced patients with esophageal cancer that were not candidates for radical surgery, and looking into how the rate of severe CTCA grade 3 or above were within the first 14 days after treatment. Again, I think it's very impressive results, and you can see this across the patient groups. This is some of the patients treated with, as you can see, advanced esophageal cancers. And these are the data 4 weeks after and 8 weeks after. And one of these effects of this treatment is clearly, as also indicated by the author group, that there might be a room for symptomatic relief of these patients where obstructive symptoms are a major issue in a palliative setting. And this is just a PET MRI response 4 weeks or 8 weeks after surgery, again showing that there is an effect both on the MRI scan and the PET scan. So another group also looked into the other part of the gastrointestinal system. So this was in patients undergoing electrochemotherapy for colorectal cancer, and Declan was also a part of this trial with recruiting patients from Ireland. I think it's again one of those trials, small group of patients. I think it was 7 patients that was included, and very interesting to see the effect on the different patient groups. And again, I'm sorry for these small or busy slides. It's just to show you the treatment trajectory of the patients and the follow-up with the endoscopies and biopsies. But what's important is actually to look here on the treatment outcome. So these first 4 patients were from Ireland. The first 2 patients had repeated therapy and actually had partial response on the first treatment and then complete response on the next 2 on the second treatment. And one patient had in Denmark had a complete response. So again, interesting to see in advanced colorectal cancer that a couple of treatments with bleomycin added electroporation, reversible electroporation, can actually produce some clinical endpoints that is highly intriguing and interesting, and should definitely be tested in the future for probably a subgroup of patients in the beginning, because we also have effective treatments with radiation, obviously. But given that there is also a considerable side effect of radiation, and that bowel preservation is a focus across tumor types, this is certainly a serious contender for the future, and in particular in combination therapies, which needs to be explored more in the future with respect of immune oncological therapies. I got a couple of more presentations. This is the Danish patient from the same group showing this interesting picture of fibrotic tissue. In the follow-up, you can see that this is the primary tumor, and 6 weeks after treatment, there is a heavy local response showing that there is a strong effect on the tumor level. This is one of the patients that we treated with calcium electroporation, and this is actually immediately after deploying a systematic treatment along the tumor side. And I think it's clear for everybody that the tumor is kind of suffering here. So just minutes after the treatment, we can see ischemia. And actually, some of my patients have been saying that the first bowel movement after giving the treatment, the patients actually expelled chunks of tumor tissue. So there is a strong local response, and both based on animal studies and strong in vitro trials, we can confirm what is seen in the clinic as it is in basic trials, that the normal cells are not suffering, so to speak, but it is clearly the tumor cells that are the focus of the detrimental effects or the therapeutic effects of the electroporation. This has ignited a trial in our group that is active here from actually this month, where we are including patients with rectal sigmoid cancers where they have symptomatic rectal bleeding, because this picture, as you can suspect, is also, as I said before, is generating a ischemia and a contraction of the vessels. So we have seen several of our patients that have been treated that had symptomatic treatment, that these patients stopped having rectal bleeding. So now we are randomizing patients to calcium electroporation or any other standard therapy decided for these patients, also giving the possibility for repeated treatments and looking into symptomatic relief in 3-6 months after the treatment. So what about calcium electroporation in advanced colorectal cancer? This is one of the cases that we have from our clinic, a patient with a high rectal tumor, and looking in follow-up 12 weeks after the tumor, where we cannot see any tissue showing any residual cancer cells. We did multiple biopsies all the way and could not demonstrate any dysplasia. This is engulfing mucosa. We could see the fibrin around the mucosa, and did multiple biopsies and could not see any tumor tissue left. The patient had metastatic disease and now have advancement in his both lung metastases and liver metastases after 6 to, I think it was 8 months of the primary treatment. This is a head and neck trial from another Danish group by Dr. Wessel, again looking into adverse events and again presenting these singular patient cases. And this is in head and neck cancer, showing and this is in recurrent head and neck cancer, showing a complete response these 4-5 months after giving them the electroporation. So in rectal cancer, I will have a couple of more slides, and I will stop my presentation and we can start discussing. In rectal cancer, we are looking into the translational data now in a randomization of 16 patients who had locally advanced rectal cancer. These were all patients that had radiochemotherapy. So these were long course radiochemotherapy, and after 8 weeks of cessation, I'm sorry, 4 weeks after the cessation of electrochemotherapy or the radiochemotherapy, the patients were treated with electrochemotherapy or went straight to surgery after 8 weeks. So the initial results are these. Of those 6 patients that underwent intended curative surgery, 3 of the patients had achieved complete pathological tumor response. An additional 1 patient did not want to have surgery because there were clinical complete response, and he's still with a complete clinical response. And 1 patient with disease progression of her liver mets, which was unrelated to the study treatment. So I hope it is clear, based on these preliminary and early trials in rectal cancer treatment and in upper GI cancer treatment, that there are certainly a visible clinical effect, a pathology, histopathological effect, and now also having the first trials, and this is a trial from our group again, where we're looking in, we are now into patient number 21 with early colon or rectal cancer, and taking out the tumor and looking into the immune response. We can actually demonstrate, I know this is a quick review, so to speak, of histological pictures, but when we are looking into the biopsy specimen before we're giving calcium electroporation and looking into the tumor resection, we can actually see an increase in the infiltration of CD8 positive cells, and also in PD-L1 expression compared with the biopsies. So these are all outcomes that we're looking more into within the next couple of months, and hopefully we will try to make an overview of what levels of effect there is and in what patients. So I'm expecting that it's not all patients that will have an effect, but I think that there are some histological subtypes of patients that surely will have a strong effect, probably something to do with the already immune infiltration of CD8 positive cells. So in conclusion, I think that it's clear to say that the modulation of the tumor microenvironments should be a major focus for us treating patients with gastrointestinal cancers. Electroporation may induce the effects which can be beneficial for the symptoms, obstructive symptoms, or GI bleeding. And which the last point is what I hope that I've also made clear, that electroporation may certainly induce some microenvironment effects that can be utilized for symptomatic relief, but most ideally and hopefully also we will be able to demonstrate this in combination with immunotherapies. So thank you for the attention, and I'll stop sharing my screen, and if you have any questions, I'll be happy to have a discussion.
Great, thank you so much, Ismail. That was a fantastic presentation, a real tour de force of the role of the immune system, and, like you say, modulating the response and the potential positive outcomes for many cancer patients. That's really exciting. So yeah, so to all the audience on the webinar, if you'd like to raise any questions for Professor Gogenur, if you'd like to do it now, we can address those. I see one question here from one of the audience members. What are the specific requirements for the endoscopist's point of view in terms of training and competence to deliver the treatment with electroporation? So what are your thoughts to that, Ismail, in terms of people using the technology?
So the experience from our group, Declan, is pretty straightforward. There is a learning curve, so to speak, with respect of getting it into the hands and understanding how to place the scope. I think the initial response from our endoscopists when they made the first couple of treatments was to kind of put in the action of the retractions from the patient's pelvic area when we did the treatments. With the new EndoVE system, it's less of an issue, so we have less muscular contraction, so that noise, so to speak, has been reduced. And I think that I think it's safe to say it's pretty straightforward, because the system to operate the machine and to place the electrode is within the competencies of any endoscopist. So having a systematic approach by starting orally and going around the clock and going anally around the clock is something that our endoscopists are doing, and are producing a good treatment within, I would say, within minutes, so 3 to 5 minutes to treat a standard tumor.
Great. Okay. So a question here from Mr. Parsons in Nottingham. Have you tried using electroporation in early tumours or dysplastic lesions?
Yeah, so we have an entry criteria for our trials and our patients, that they needed to have a positive histology. So it was not only dysplastic lesions, but they needed to have adenocarcinoma. Actually, our trials are now focusing on the early colorectal cancers. So we are now running on patient number 21 in sigmoid and rectal cancer. And I think that what would be interesting is, for our strategy, it has been to kind of demonstrate what happens to start with, before we are looking into the clinical placement of this treatment in the future. So we have now treated 21 patients with rectal or small sigmoid cancers, where we operate them within 7 to 10 to 11 days after the treatment. Here, clearly the focus is to demonstrate if there is immune activation. So hopefully, when we can demonstrate this, and I showed you a couple of slides showing that there is an immune infiltration, etc., the next step will clearly be to try to extend that period, and then see within a 4-week or 6-week part, how is the continuous response of that immune activation, and how does that demonstrate when we are re-evaluating or restaging the tumor after 4 to 6 weeks. This would clearly be interesting, particularly, I think this is where the question comes from, right? It's for those patients with a high risk of surgery-related complications, who has the small tumors, if this could constitute, so to speak, the only treatment for these patients. I think this is clearly a very good question, and maybe an area where we can have an effect in the future.
Great, thank you. So if there's any other questions people would like to ask, please feel free to do so. In the meantime, in terms of using bleomycin or calcium, obviously historically with electroporation, reversible electroporation, that started really using it in combination with bleomycin. And then more recently, thanks to research by Professor Julia Gell's group in Denmark, the option of using calcium has come to the fore. And you presented some nice data on your initial experiences with using calcium in GI cancers. Would you have a preference of using one over the other, or do you see, maybe it's too early to say, but do you see any changes immunologically with using one option over the other, and do you have a preference?
I think that's a very, very good question. This is something that is clearly in our scope for answering this question, because we are, let us talk about what advantages that is in a clinical setting, right? So when we're using bleomycin, there's obviously the possibility to have pulmonary side effects of the bleomycin. So we have a group of patients that might not be candidates for this treatment. So this is the clinical concern. And in this aspect, calcium is a strong candidate if it can generate the immunological effects that we want. However, bleomycin is also a very strong candidate for the activation of the immune system that we see due to its effects intracellularly. So I think that it is very difficult to give any answer on this unless that you have a group of patients that have only bleomycin and reversible electroporation, calcium and reversible electroporation. And actually, what we are doing in our unit right now in early cancers is also just to give reversible electroporation. So seeing what is the add-on effect of calcium or the bleomycin in addition to electroporation. And I hope that we will be able to answer this question the next year when we're finalizing our trials. This was a diplomatic answer, Declan. I don't know if you have any comments on how you're seeing this, but
yeah, it's all driven by the clinical evidence, like you are collecting, and yeah, I look forward to hopefully meeting in person and seeing that data presented when the time is right. Okay, so another question here: is this applicable to a squamous cellular anal cancer in a cirrhotic patient who has refused surgery with radiation already done?
Wow. This is a very good question. I would hope that I could answer this more precisely, but I think that the squamous cellular data on skin cancers maybe be able to be transferred to the anal cancer. Actually, I don't have any recollection of data out there regarding anal squamous cellular carcinomas. But this is an excellent group, right? Those patients that have immune compromised situation and having local symptoms and are not responding to radiation therapy. I'm expecting, based on the skin data, so to speak, that there might be an effect, but I haven't seen any data on anal cancer.
Yeah, great. Okay. And then a follow-on question from Mr. Parsons: is bleomycin working as a cytotoxic agent or an immune stimulation agent?
I think the last first and the second next. So it's cytotoxic in this inducing in the process. I think it's difficult to clearly say the chain of actions, but you are starting a apoptotic event and cytotoxic event, and then you have, all kinds of phases of cellular damage, right? So you have the antigen presentation and the secondary immune activation. So I think that's probably the way that it works.
Sure. Yeah, great. Let's see. I think that's all the questions for now. So unless there's any other questions anyone would like to raise, well, I think you've been very generous with your time today, Professor Gogenur. Thank you so much for sharing it and for sharing your clinical experience with electroporation. And I think, we've obviously been on the same page with regard to the importance of the immune response for a long number of years. And I think it's very exciting to see it presented in the fashion that you have today. And I think it gives great hopes to many cancer patients now and into the future that the work that you're doing and the clinical evidence you're building would help to provide for better outcomes for those patients. So really excited to see this story continue and develop. And I look forward to hopefully our next webinar being in person at maybe the World Congress for Electroporation meeting, which is pushed to next year. So thank you very much, and thank you for your time.
Thank you very much for the kind invitation. Thank you.